Hello, everyone. We're pleased to have you join us for Cardinal Health Lab Exchange. Welcome to today's live broadcast, Clinical Laboratories Go to Washington. I'm Brenda Kelly-Kim of Laboratories, and I'll be your moderator for today's webinar. We're delighted to bring you this educational web seminar presented by Laboratories and sponsored by Cardinal Health. Cardinal Health is a Fortune 22 company that improves the cost-effectiveness of healthcare. As the business behind healthcare, Cardinal Health helps pharmacies, hospitals, and ambulatory surgery centers, clinical laboratories, and physician offices focus on patient care while reducing costs, enhancing efficiency, and improving quality. Cardinal Health employs more than 34,000 people worldwide. For more information, please visit www.cardinal.com. We have a few important announcements before we begin. We've designed this webcast to be interactive, and we hope you ask questions during the event. You can submit your questions by typing them in the Q&A box, which can be found by clicking on the bright green Q&A button at the lower left of the presentation window, and we'll try to answer as many of your questions as we can today. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. And finally, if you have any technical problems viewing or hearing this presentation, let us know by clicking on the support button at the top right of your presentation window, or submit your problem through the green Q&A button on the lower left. I'd now like to introduce today's speaker, Thomas Sparkman. Tom Sparkman was named Vice President of Government Relations for the American Clinical Laboratory Association in March 2013. Prior to joining ACLA, Mr. Sparkman was a senior lobbyist at a top lobbying firm in Washington, D.C., representing biotech and medical device innovators, hospitals, and other providers, among others. Joining the firm in 2008, he helped build coalitions on and off Capitol Hill to achieve his clients' legislative and policy goals. Mr. Sparkman has also held positions with the National Association of State Medicaid Directors, the National Association of Chain Drug Stores, in addition to having practiced as a pharmacist in Northern Virginia for over 10 years. He holds a Bachelor of Pharmacy from Rutgers University, a Master's of Public Policy from Georgetown University, and a Juris Doctor from American University, and is licensed as a pharmacist in the Commonwealth of Virginia, and is an associate member of the Virginia State Bar. I'll now turn it over to Thomas for his presentation.
Thank you, Brenda, and thank you for Cardinal for inviting me to present. It's always a privilege to get to talk to the laboratory community and also listen back to what everyone is interested in and see what topics are of most concern. As Brenda said, I work for the American Clinical Laboratory Association, and just to tell you a little bit about them, we're the premier trade association in Washington, D.C., advocating on behalf of clinical laboratories specifically. So we don't represent, for instance, physician-owned laboratories, rather the independent laboratories, and that includes the large national labs such as Quest Diagnostics and LabCorp, more regional labs such as AccuLabs, to medical center labs like Mayo, Cleveland Clinic, ARUP with the University of Utah, and also esoteric, or what I sometimes call innovator labs such as Myriad Genetics and Genomic Health, which have the very famous BRCA tests. And as Brenda said, as a pharmacist attorney with a master's in public policy degree, I'm happy to chat with you about anything, whether it's why we have employer-sponsored insurance, to the Affordable Care Act constitutionality, to your everyday allergy meds. So before we get started, I'd like to poll the audience and see where you all come from and what your greatest concerns are. And I think some polls are going to pop up on your screen here. The first being what type of laboratory practice do you have? Where are you coming from? And then the second question will be what you view as the number one issue facing your laboratory or industry. Okay, so and Tracy, if you can share the results. I'm seeing the results for the first poll showing up on my screen. Just give it a second for it all to come through. appreciate everyone clicking in here. Okay, wow, some interesting results here. Okay, so the results of the first question of what practice, we have a third from hospital laboratories, and then another third from a national laboratory, and then a third in the other category. Perhaps we'll find out more about the other category later. And then as far as the number one issue facing laboratories, it's surprisingly dominant in terms of coverage of new tests as opposed to reimbursement levels or laboratory oversight or health information technology or anything else. So that's really impressive and understandable, as we'll discuss moving forward. So moving on, let's just get rid of these pop-ups here. So being a pharmacist first, I always have to start off with a drug joke, and here we have the cartoon speed bump where the nice little old lady is walking through what each of her pills are for, whether it's for her back pain or whether it's for her hip, or as she puts it, to help her forget how much this is costing me. And as much as I'm putting this up here for a laugh and to be tongue-in-cheek, it's also very important to me, having practiced as a pharmacist, that remembering no matter what I'm doing in healthcare or up here in Washington in health policy, that everything always comes back to the patient. I'm never going to forget working on a busy Saturday in a grocery store pharmacy, and a woman, we were having trouble with her insurance. And I was asking her questions, and she just kind of stopped talking for a minute, and kind of holding back the tears, said it out loud that her husband had just been diagnosed with pancreatic cancer that morning. And of course, anyone who's been in those kind of moments realizes how confusing and overwhelming everything can be. And really, at the end of the day, all of us, whatever level we work and operate at, we always have to remember that it just comes down to the people and the patients and making sure that they have everything that they need. So stepping back, looking at your entire conference that you've attended over the past couple of days, you all have covered a number of issues, whether it's reimbursement, looking at infectious disease or cancer, hearing about personalized medicine and maybe what the nuts in Congress are working on, and how that might internally affect your organization. But what I'm hoping to talk about and cover here today is how you can also make an external impact, and why that's going to be important for you, both individually and as an organization. And to really bring this home, this is one of the most striking and important quotes I've run into from the early 20th century, that the absent are always in the wrong. And you can look at this from two perspectives. One, if you're absent, it allows your opponents to tell your story for you, and more importantly, tell the story they prefer, and push forward their objectives, neglecting your own. And two, if you're not present, you can't voice your point of view, and you can't voice the impact and how a policy issue is going to be detrimental to you, your organization, your employees, and as we've discussed, your patients. So really keep this in the back of your mind as we go forward. And that gets me to the key points that I'm going to want you really to leave this presentation with today. One, as I said, others are going to be happy to write your narrative for you, particularly to their advantage. To the picture in healthcare, the big picture in healthcare is evolving weekly, monthly, even daily. Whether it's with Medicare, whether it's with the various state Medicaid programs, private insurers, or the larger Affordable Care Act debates, These big picture trends are evolving about how we deliver healthcare overall, and that's going to affect every provider, obviously, including clinical laboratories. And then third, within clinical laboratories, we are seeing some very critical paradigm shifts that are happening now, and we'll talk about those in a minute. But they're going to be the environment that laboratories have existed in for the past 5, 10, in some case 30 years is indubitably going to be different going forward in the next 2 to 5 years, and we'll talk about that more. And in dealing with these big picture trends and these laboratory-specific paradigms, it's going to be critically important that you commit with your presence. And we'll talk about what that means, and part of what that means is engaging policymakers. And when you engage policymakers, and this can be locally, this can be at the state level, this can be with Congress, this can be with the agencies, or even at the presidential executive level. And when you do engage, this has to be consistent and educational. One of the things that you'll hear from congressional staffers is that they only hear from their constituencies and they only hear from stakeholders when things have already gone wrong. And everyone's kind of in an airdrop panic mode, that the sky is falling, the world is going to end tomorrow, and we need you, Congress, to enact this legislation immediately. And of course, at that point, whether it's at the staff level or at the congressional level, they haven't had the opportunity to educate themselves on the issues, and certainly not in any way where they can objectively view what the true source of the problem is, and what a true solution might be. Sometimes, they'll rush to a solution, and that solution might end up being a bad solution. But oftentimes it's very easy for them to choose to do nothing, because whatever policy is causing the problem was put in place for a reason, and rather than question an agency or reopen statute, it is, and especially if there's stakeholder disagreement, it can be just easier for them to do nothing, and then whatever problem that you had risen with them, is just going to continue to fester and be harmful to your organization. So getting to this first point of others writing your narrative, let's look at a couple examples. So in the August, actually I think this might have been, okay, it was 2014. August of 2014, the Health and Human Services Office of Inspector General issued a report, as you see here, that cover questionable billing practices and Medicare Part B clinical laboratory services. The Office of Inspector General hadn't reached out to laboratories on this. They hadn't really told us that they were working on something. They just came out with this report, which had approximately 13 metrics by which they were going to measure whether or not a particular billing practice was quote unquote, appropriate or questionable. And, and they made a big splash. They went into the Wall Street Journal and said, oh, clinical laboratories are, fudging the books, and they're costing Medicare hundreds of millions of dollars. And, this is really wrong, and, Congress should do something about it. But when you actually get into the report and look at the metrics, you find that really they weren't very well designed to objectively analyze laboratories. The best example of this is whether or not the patient address was 150 miles away from either the ordering physician or from the clinical laboratory. And to be honest, if you think about other Medicare services, the best one that comes to mind is like prescriptions for the painkiller OxyContin. The proximity of the patient to the doctor and the provider, or the pharmacy in the case of OxyContin, would make a lot of sense. You hear a lot of stories about drug diversion, people traveling between Tennessee and Florida and Georgia and Alabama, traveling hundreds of miles to get as many pills as OxyContin as they can, and perhaps they're addicted and they're abusing the tablets, or perhaps they are selling them because, there is a street value. That's something as a pharmacist, I had to be very conscious of. But if you think about that metric, 150 miles from the provider, in terms of laboratories, if you think about it in terms of laboratories, well, a patient specimen routinely travels very far in comparison to where the patient's physical address is. Because not every laboratory, not every physical laboratory, and certainly not every laboratory institution as a whole provides every single test. And so it was a completely and wholly inappropriate metric for the OIG to call out as questionable. And there were a couple others that were similar, they decided to discard physician-owned labs in self-referral situations, which is an issue that ACLA has worked on for a number of years, and just wholly exclude that data, to not look at trends in there. And further, if you actually looked at their own numbers in the report, they looked at they were lumping all the lab categories together, essentially, and weren't breaking out physician office labs and independent labs and clinical labs. So, when we finally got a hold of the report, ACLA, did engage with OIG to talk about it and also prevent further reports of this nature. But, it very much is already harmful once this is out there and folks like the Wall Street Journal are reporting it. And again, so the second example I have of someone else writing a narrative is a very recent article that we saw in the Milwaukee journal Sentinel, where they painted a very bleak picture about oversight of laboratories. And this particular article focused on what appeared to be essentially anecdotal cases of problems either with internal lab safety procedures in particular single instances, or problems with the analytical validity of laboratory tests. And I use this just as an example of, folks are happy to write about something that they think is going to make a splash or an impact, to be crass sometimes, whether it's a reporter or whether it's a government instigator. They're, justifying their existence because, oh, look, I found the bad guy, and we should go after him. But, it really creates, reacting to this, it creates the most work, and it's the hardest to respond to, because these are just going to be out there in perpetuity, searchable by Google, and any new player comes in, they're just going to use something like this to wave around. We've seen news coverage like this also on Lyme disease testing, and I'm sure all of you know some of the controversy around Lyme disease. And we've seen reporters just trying to blame the laboratory industry writ large, where really it's an open question in medical science about whether chronic Lyme disease exists. There are diagnostics, even FDA-approved diagnostics for people who want to tout FDA. FDA-approved diagnostics for acute Lyme disease. You've got the Western blot and the antibody test. But they're very willing to paint these extremely broad strokes and really ultimately do harm to the industry and discredit to the amazing professionals that work in these laboratories for the betterment of their patients. So how do we deal with this, or when do we need to deal with this? So looking at the big picture trends that we talked about a couple of slides ago, we're looking at continued coverage and reimbursement pressure, and as all you indicated, it's the coverage of the test, and I'm thinking back to the wording of it, I'm referring to the insurance coverage of the test, whether that's through Medicare coverage decisions or whether through private insurance. We're seeing across the board pressure. It doesn't matter whether you're a laboratory, a skilled nursing home, a long-term acute care hospital, or a regular hospital. Everyone wants to simply just pay less. Even historically out of CMS, we've seen trends where they would rather than actually looking at the policy and why a clinical test service is being prescribed as often as they'll just presume there's malfeasance and that the test is overpaid or the price is too high and that's why people are ordering it, and so they'll just lop off a double-digit percentage off of the code and say problem fixed. We've saved Medicare because we're paying labs less. The other paradigm we're seeing out there is value-based payments. This was really big in the SGR, the Sustainable Growth Rate repeal and replace in Medicare that Congress enacted just a few weeks ago, and I believe was covered in one of your earlier presentations. This is getting to the idea of just not simply paying for volume anymore, but paying for better healthcare outcomes. If I'm looking at a diabetes patient, are they actually controlling their sugar? Are they staying out of their hospital emergency room? Are they keeping all their fingers and toes and their eyesight? As opposed to someone who's continuing to degrade, leading to heart disease, congestive heart failure, and all that sort. So trying to get to this idea of paying for the value instead of just paying for volume. And it's really a leap of faith for everyone, right? Because volume is very easy to measure and it's very concrete, whether you're a regulator, a payer, or whether you're actually the provider. But we've seen, and particularly at the family physician level, that too much focus on volume does ultimately hurt the patient. And so that's what we are trying to do, is move towards value. And this gets to the third point about we're seeing folks trying to shift around the risk involved in healthcare spending specifically. If you look at proposals you've either seen out of the Centers for Medicare and Medicaid Services or even proposals out of Congress, what they're trying to do is get the government, essentially reduce the government's risk profile. And this gets to the volume issue. If the government just says they'll pay for everything, then they're at risk for, essentially an unlimited volume, right? And that creates a great risk of breaking the bank, overburdening the taxpayer, and everything else. So that's what leads to models such as the Accountable Care Organizations we saw out of the Affordable Care Act, and other value-based models, because they're trying to shift risk actually to the providers. Basically saying to the providers, it's up to you to do better with the patient, and if you don't, then we're not going to pay you as well, one, or even worse, they're going to penalize you. And we've seen examples of that, where hospitals can now get penalized for a bad readmission rate if the patients are coming back with further problems after having an inpatient stay at the hospital. And then, of course, what gets me the most excited about working with clinical labs, and I really don't want everyone to take away doom and gloom, because there is excitement. There is very exciting innovation occurring out in healthcare, and specifically in clinical labs. This concept, even back when I was back in pharmacy school in the 90s, you were essentially looking at, just singularly cancer in an organ-based mindset, whether it's prostate cancer or breast cancer. But as we've progressed over the past 15, 20 years, and I'm getting to my 20-year anniversary from all this, so taking a moment on that one. But anyway, but what we've seen in the past 15 to 20 years is that we're breaking out cancer into subsets. It's not just breast cancer anymore. It's actually at least five different diseases, and the same with melanoma and everything. So this kind of gets to the value proposition for laboratories. If we're able to more precisely and more accurately diagnose the disease, then we can more precisely and more accurately make the decision, one, do we treat? Two, when do we treat? And three, how do we treat? And those are huge questions. When you see everything in the news about new drugs costing tens of thousands of dollars, and we all know that chemotherapy costs hundreds of thousands of dollars. Not every chemotherapy, but many of them. If you can make the decision to not have to spend that money. If you can say to a patient, just like, you're okay, we can just observe and that's fine. We don't have to spend $300,000. That's great, particularly from the cost side. But thinking about it from the patient side, they don't have to go through an uncertain treatment. They don't have to risk the adverse events, losing their hair through chemo is one example, the exhaustion, the bed confinement, and just, and also the burden on the family and the caregivers. And that all starts with better diagnostics and better laboratory diagnostics. And there's real excitement about what we're seeing in that regard. And so, and that's really because of you all on the phone, on the webinar and on the phone here, because you're really pushing forward to try to get this innovation and access. So zooming in on the laboratory and what we're seeing, really paradigm shift here. We have the reform of the Medicare clinical laboratory fee schedule, and you heard about that a day or two ago, if not both days. This was through the Protecting Access to Medicare Act that was enacted, I believe, April 1st, 2014. We're going to move from a static Medicare fee schedule for clinical laboratory services to one that, quote unquote, follows private market prices. And we are eagerly awaiting CMS to put out their proposed rule as to how this is going to be implemented. Statutorily, they were actually supposed to have that out by June 11th, but I mean today's June 11th, by June 30th, but they don't even have the proposed rule out yet, so they're certainly not going to have a final rule by the end of this month. At this point, we're starting, and ACLA as an organization has met with CMS multiple times and has continued to bring us up that we need to know how this is going to be implemented, because we're getting down to 18 months because the new prices are supposed to go live January 1st of 2017, which means the data collection really has to happen earlier, much earlier in 2016, so that CMS can crunch the data, publish what the proposed new prices would be, and allow for everyone to analyze those and comment them and eventually get to the final prices in time for January. No one wants to be in a situation where laboratories have too short of a time to compile the data to make good submissions, good data submissions to CMS, and certainly not, and certainly don't want to get caught surprised on Christmas Eve with new final prices that are, could potentially, be bad prices, shall we say, and then only have 7 days to either implement or respond, because that could just lead to disaster organizationally and potentially harm our ability to provide these services to patients. So second, we have FDA threats to regulate laboratory-developed test services as medical devices. This has been one of my primary charges in the organizationally, and really a huge concern, and gets back to squelching that excitement I was just talking about and the innovation of clinical laboratories. Basically, the FDA last year proposed that they want to regulate laboratories as if they were medical device manufacturers, so that they can start requiring pre-market approval for any new laboratory test. And there's various exemptions that they've tried to build into that proposal and that sort. And really, when you start getting down to it, laboratories just aren't medical device manufacturers, and the laboratory-developed test services that we provide are not equivalent to the IVD test kits that are sold in interstate commerce and packaged and manufactured and all that sort. So we've been talking to Congress about our concern with this proposal, and both the House and the Senate are engaged on the issue, and we're continuing to see if there are potential alternatives to what the FDA has proposed, so that laboratories can continue to provide quality services and also continue to innovate and get these better, more powerful diagnostics available to patients. The third is slightly, I've mentioned before, with the new payment models for physicians, it's going to be interesting to see how these payment models evolve, because laboratories as ancillary providers might enter basically service agreements where they're not being paid directly by the insurance provider or by Medicare or something. They're actually receiving their payment through the intermediary, potentially as a physician or a hospital and that sort. I don't have any particular concrete examples, but it's something you can conceive if you're going to start getting back to these concepts about medical homes and how the accountable care organizations work, and how the laboratory fits in that, and making sure that the patient has full access to every diagnostic that they have. If models like that continue to roll out or be proposed or implemented, it'll be very important that laboratories are at the table, making sure that all the services are available. And then precision medicine is something we've seen a lot of coverage on, because the president himself has taken notice of this, with both at the diagnostic level and at the drug level, getting back to this concept of making sure that the patient is diagnosed to the individual patient level as opposed to a population-based therapy, and actually is getting the appropriate treatment. But the FDA or the NIH, from a research perspective, the NIH might not necessarily be rigged from a regulatory perspective to handle let's say 314 individualized diagnostic and treatment plans if we were going to do everyone in the United States. We're certainly over 300 million people at this point. So this is just, again, the excitement of innovation. So okay, so we have the big picture trends, going back a slide, and then we've got the new paradigms. So what do you do with this organizationally, and and how do you make the external impact? Namely, how do labs tell their story? And a couple more comic strips, because after all, it's Thursday afternoon, getting to the end of the week. Not everyone wants to take drugs, but kind of doing it tongue-in-cheek. The idea of like, what if pharmacy gave free samples? Laboratories certainly can't give free samples per se, and most certainly in the second cartoon we have a gentleman who appears to have just about every facial piercing he has, but still really, really hates needles. And we in laboratories are still very much in the business of venipuncture and drawing blood. So in addition to that, the laboratory professionals, whether it's the pathologists or the laboratorians, are certainly one of the less visible members of a patient's healthcare team. Really almost only comparable to perhaps the anesthesiologist in the operating room, where you're not, as a patient, you're not going to meet your pathologist, generally speaking. You're not going to meet the laboratorian or the geneticist. There's certainly call-in counseling opportunities, but and you're also not going to see the laboratory processing in all likelihood. Many of these tests, your only visual is where you get your blood drawn. Sometimes that's in the physician office, sometimes that's in a collection center, sometimes that's in the nursing home. So this creates a challenge, because it's not necessarily a product that people rush in and really want, like an iPhone or something, and it can even have kind of those negative connotations. So how exactly do you tell your story? And this is where we get to committing to your presence. And there are various ways to do this. We're going to talk about Capitol Hill in a little bit, but we saw examples earlier about negative journalist coverage, and one way to tell your story in a positive way and tell it in an impactful way is to essentially engage preemptively. I talked earlier about taking a posture of just being reactionary, and in that case the problem has already occurred. There's already a worst case scenario in front of you, and you're in mitigation mode as opposed to being proactive. So you want to be able to start pushing out stories, and you engage at all levels. You want to engage the media. You want to engage policymakers. Now, the examples I have on the screen on this slide right here are, for the most part, actually reactionary, but they give examples of the media. So with the Miami Herald, we have a op-ed penned by Doug Van Ort, who works for Neogenomics based in Florida, one of our member labs. And some of the examples you're going to see in this slide and other slides date back to 2013, when there was a very negative proposed reimbursement out of CMS, where they were going to start bundling, resetting prices under the clinical lab fee schedule based on prices they had elsewhere in the hospital outpatient bundles. And it was one of the, from an advocacy perspective, it was one of those great moments when many forces came together to turn back that policy, which, to ruin the end, we were actually able to turn back that particular policy in 2013. We were turning to the examples of how we dealt with it and created our presence in response. So we have member companies who are penning op-eds in impactful papers. Miami Herald. Miami is well known for having a huge Medicare population, so members of Congress are going to care a great deal from that community of Miami about what might be in the Miami Herald about particular issues. On the top right, we joined with a number of other industry stakeholders to really decry this proposal, and you see, you see AdvaMed DX, you see the College of American Pathologists, the Association for Molecular Pathology, and others on this. And really, so we were able to come together on this issue, but it really wouldn't have been possible if it hadn't been in the first place that ACLA members and ACLA as an organization weren't already engaged in a dialogue with these members. It's a lot harder to rev this up if folks aren't communicating to begin with, because then you have to start from square one. And then the last example we have here is what we call earned media, where we have a reporter writing about the issue, which is you have the inserted media, so to speak, with the op-eds where we generate the content, and then there's also working the reporters. Now, in terms of Congress, Congress has many levers, and depending on the issue and the status, it will alter what you're asking them to do. In this particular slide, we have examples of the congressional letters that were engaged on that reimbursement campaign back in 2013. We had well over 100 members of Congress, which might have actually set the record for a laboratory issue, to write the agency and really decry how ill-advised the proposed reimbursement policy was, and really urge the agency to turn it back. And as I said, ultimately they did. But in addition to just writing letters, Congress can also play a more behind-the-scene roles. You can urge your representative to just simply call over and inquire of the agency their rationale, to really, like, okay, agency, you're saying X and that you want to do Y, but I need to know all the basis for why that's happening, and really put the agency in a position where they have to react and justify their action. And of course, there are congressional hearings, and then of course, actual statutory action, passing legislation, which can be a little bit more complicated and maddening, but it can be viewed as a last resort because changing law is a big deal, but it's certainly part and parcel of any sort of engagement strategy. And as I mentioned, it's something we're talking to committees about and stakeholders about, particularly on the FDA issue right now. But let's talk about this a little bit, how you all on this webinar can engage both individually and organizationally. So in this next slide, we actually have a picture here of Chairman Fred Upton touring a lab at the University of Michigan. Fred Upton from Michigan is the chair of the All-Powerful Energy and Commerce Committee, which has jurisdiction over the FDA, the NIH, even CLIA, and certain portions of Medicare. And one of the things that we do at ACLA is that we actively work with our member laboratories to see if we can get members of Congress and policymakers to actually come into their facilities, so that a laboratory is no longer just the collection point where they're seeing the needle and the blood draw. It actually becomes, they can actually conceptually visualize it and understand all the professionals that it takes for a laboratory to operate and operate safely and with a high level of quality to serve their patients, and also work with physicians who are ordering the tests. I've had the privilege of touring, going on 2 different lab tours, and I can't explain the impact this has either on members of Congress or congressional staff, because you actually see the pathologists walking through walking through the lab with either the samples or the slides of the biopsies, and you actually see the dark rooms where they're actually going through the slides with their microscopes, and you start to really get a picture of what's happening. It's not just being processed through some machine or computer analyzer and then spit back out magically to your physician. They're actually highly trained, highly qualified people that are working these processes. Of course, there is some level of automation, and it's important for them to see that too. But doing this really makes policies understand, there are actual constituents behind the laboratory and within the laboratory, and understanding that, one, they really care about providing the best service for patients, and 2, a negative impact on the institution of the laboratory and how the laboratory can provide these services is going to also have a local impact to the community, whether that's the patient community that the laboratory serves or even the local community, from the perspective of, the folks that work in the lab are employees, and and they live in the area, and their kids go to the schools, and they're buying groceries at the grocery store and mowing their lawns and doing everything, and being part of the economy and the community, and it's inordinately valuable, and it's just not something members of Congress or their staff are going to think about when all they know about a lab is they need to get blood drawn, and then they're handed a lab report by their physician, or these days some folks email it. So it really puts it in perspective, getting these policymakers into your lab. And, and it's a little harder to do, but you can do this at the agency level too, whether we're talking about state health authorities like Medicaid or whether we're talking about CMS. That's a little bit rarer, but it's certainly in the realm of a possible an example. So let me just make sure I'm covering all my points here. So those are just kind of examples of, like how you would engage and what type of activities you're undertaking to engage. There are, of course, traditional Capitol Hill meetings where you're coming to Washington, D.C., and you're actually meeting with the staff or the members here in D.C. And there's also, it's important to remember the district congressional offices as well for both members of the House and members of the Senate, because they all have offices and staff within their states and their districts. And sometimes when organizationally as a laboratory, that can be a great place to start, because those folks in those district offices, their charge is to take care of the home team, take care of the constituents and make sure that any issues they're having are being addressed. And of course, that usually, with something dealing with Medicare, they're going to have to put that up the chain of command, which gets to the DC staff. But they can be the dog with the bone at the district level to make sure that your actual member of Congress and your senator have the information that might be critical. So those are just examples, and if folks have questions, we can talk more about that. So we reviewed the fact that others will write your narrative for you if you're not present, if you're absent. We've talked about some of the big picture trends that we're continuing to see on the horizon, and again, you've reviewed some of these in some of the other presentations during this conference. We've looked at some of the paradigm shifts that are affecting the laboratory community, and we've talked about ways to use your presence, whether it's with the media or with policymakers, and and social media. Don't forget social media, because that's a great way to, especially with the positive messages. If you're innovating new tests, advertise why that's valuable. And social media is a great way to do it and to celebrate it, and even engage the patient community. And there are likely rules around that that I can't get into, but it's just another avenue, and we're only seeing more of that social media engagement, whether it's Twitter, whether it's Facebook, Instagram, what have you. So with all those thoughts in mind, it brings me to my second quote here from the famous Jack Welch from General Electric. Change before you have to. We're seeing these incredible shifts in healthcare and some really potentially incredible shifts with laboratories specifically. And so and the way you change and stay ahead of all these things is engaging in talks like today and this conference over the past 2-3 days. Because if you get caught on the wrong side of this, that's really going to harm your institution, your employees, and as we keep coming back to the patients that you ultimately serve. And so by thinking ahead about where all these trends are going, you can start to adapt your organization and your approach so that you can be part of the solution. So part of this is adapting to some of the models that are already out there, and another of it is how can we innovate? Is it just at the test level? Like what are the tests that we're rolling out, and what's the value of those tests? How can we make the value concrete? But also innovative ways to serve the patients. We've entered an age where the lab results also have to be made directly available to the patient. So what's the best way to do that? I don't know if we know that yet. I think at large we're still considering that and thinking through that. And how are we going to deal with these coverage decisions? What's the better way to go about it? Because ultimately, if you don't change, you end up in some worst case scenarios. And I'm putting this next article up not really to call anybody out, but more as an example, of basically, you don't want to end up on the wrong side of a government investigation. This is one recent example where a laboratory had to pay out, I think, around $48 million in fines, and actually just this week announced that they were declaring bankruptcy. And I think, no matter, what the facts of a particular case are, that's a bad outcome. That's an organization, a potential organization not adapting in that proactive way to best serve patients. But again, I want to come back to this point of, we absolutely need to be excited about the future, and the reason why I'm excited about the future is because of folks like you in the laboratories, and just what the incredible genomic science that we've seen over the past 15 years. These two slides are from a Hill briefing that I attended a couple weeks ago, where we had Columbia and Mayo were presenting and really talking about these amazing innovations. It is staggering to me to see the chart of how the cost of sequencing the genome has gone down so radically. And how we can make this information more usable for both the physician and the patient, and what it's going to take. Big data. I feel some labs, I believe, are doing a great job of employing big data, and there are these questions, whether from the Precision Medicine Initiative or other places, of how we can continue to better leverage the big data to have better healthcare outcomes. And the amazing thing is, these answers are going to come from you all. They're not going to come from me. I just have the privilege of bragging about them to folks up here in Washington D.C. And I love having those stories. So definitely continue the good work that you're all doing because it selfishly it makes my job easier. So just kind of end with that. So that brings me to the end of my presentation, and I'm happy to field questions. There's my contact information right there, and very again appreciate the opportunity to speak here. Thank you, Brenda, and thank you, Cardinal. And again, don't feel constrained to the subject in the slides. I'm happy to speak about anything more specifically. I just recognize that I believe I'm the last presenter, so I didn't want to get too technical in any of the slides. And of course, if I don't have the answer, you can reach out to me individually, and I can help find the answer as well. So, Brenda, Tracy, thank you.
Great. Thank you, Tom, for that informative presentation. I'm very happy to have you here as part of Cardinal Health Exchange. I just want to remind our audience asking questions is done through the green Q&A button, which can be found in the lower left of the presentation window, and we'll try to get to as many as we can. We do have a question for you, Tom, from Ginger at Greenville Health System. And what is being done about the CMS interpretation of the personnel regulations concerning competency assessment in a lab performing high complexity testing? They have CAP and TJC requiring someone who meets technical consultants to assess moderate complexity tests in a high complexity lab, even though there is no technical consultant listed for a lab performing high complexity testing. They are allowing MLT to assess high complexity testing, but not moderate in a high complexity lab.
So, Brenda, is it easier for me to type an answer or to answer verbally?
Verbally is probably best. Everybody can hear you.
Okay. All right. So I'm actually going to admit that this particular issue hasn't bubbled up to me as yet. But it is, it's certainly something that we can take a look at. And Ginger, if you want to reach out to me individually via my email address or others, I can, check with folks in our organization and see if they know anything more specifically about it. But right out of the gate, I'm going to have to admit that that particular issue hasn't bubbled up to my level yet. So.
Okay, great. We have another question. If someone in the audience wants to engage policymakers on these issues, what would you suggest as a first step?
Join ACLA. No, that's a joke. That's a joke. Actually, so really the most important question is you need to answer the question, at what level do you want to be engaged and make a difference? Because depending on who you are and where you're engaged, you can make the decision about, do I want to engage on the individual level, literally just as a voter in the United States, who, wants to talk to my congressman, or as a pathologist, for an example, thinking as a pathologist, of course, there's the AMA and other membership societies that cater to the individual level. If you want to, get involved at the organizational level, at the institutional level, then it's important that you're working with your leadership team to make sure that that strategy works within your organization. And deciding how your organization wants to get involved. Perhaps it is, joining a trade association as a selfish example. Because, individually you can, redress your grievances with your congressman, but organizationally there can be broader benefits, given whatever organization you might choose to join, whether that's at the reimbursement and coverage level, or implementation levels, so that it's not just shall we say the C-suite that, or the individual that's getting the benefit, but all levels of the organization that gets the benefit, because there are those multiple levels and multiple time windows to engage. There's when the statute is working through Congress, there's when the implementation is occurring, there's when the modifications occur, and there's when you actually have to make it work internally at the organization. And your engagement and your presence helps with all of those, and making that decision about what level you want to get engaged at, whether it's just simply individually and at that, so kind of medical healthcare professional level, or whether you think you want to mobilize the organization so that they can all get the benefit. I mean, it's an important question to ask first, before you're trying to pick any of the other steps or problems that I discussed.
Great. Thank you for that answer, Tom. I think that's all we have now. I would like to thank our sponsor, Cardinal Health, for making today's educational webcast possible. Today's webcast will be available for on-demand viewing through October of this year. You'll receive an email from Laboratories alerting you when this webcast will be available for replay, and we invite you to forward that announcement to your colleagues who might have missed today's live event. Again, thank you, Tom Sparkman, for your informative presentation, and thank you to Cardinal Health for sponsoring this presentation. We hope to see you next time. Thanks, and goodbye.